Hey everybody, how's it going? Let me know if you can hear and see me. Excuse me. Got about 4 of you guys in the room so far. Can anyone hear and or see me? I know we're gonna be missing a few people because they're talking to the ARC people, but let's see. All right, perfect. Thank you, Pedro. Just confirmation of life. That's what I'm looking for here. Hope your site vids is going well. I'm sure all of your faculty and administrators have prepared well, and things will go well. Good morning to you, Joshua, or Monring, if you will. Is it? And I don't know if I've ever said it before. Is it Bryle or is Bryle correct? How I should say it. There's a different way to pronounce. Let me know. Oh, perfect. Okay, I'm gonna go with Bryle. My first instinct was correct, which is not always the case, but okay, well it's 8 o'clock, so I'm gonna get started. I know some people, hey Kadeen, I know I think my mouse or my mic is a little hot. Turns down to here. It's too early this morning because I can't spell. Oh, that's okay. I can't usually spell either this early in the morning, but hopefully I can talk. That's important. All right, so I got the recording going. I know some people I think are talking with the accreditors, so if you're joining me late, that's no problem. If you're watching me in the past or in the future, I guess, but feel free to put up questions even if I'm talking about something else. I don't mind going backwards and talking about stuff again, you know, because it kind of helps everybody. So again, if you have questions, you post them up in the chat, put them on the sticky board. I don't see anything currently, so I think we're going to continue on with our discussion of endo. And yeah, how many more class sessions do we have? We have 1, 2, 3, 4, and so then you got your final test. So that's not too bad. I think we should have enough time to kind of cover everything. So I think we're cooking along just fine here. Okay, so we were talking about diabetes, I believe. That's the last thing we were talking about. We got through all the type 1 medications, which is mainly just insulin, right? That's what we talked about previously. Recall, you know, sort of the different ways we use insulin in terms of like how we use a short acting versus a long acting. Oh, someone said, he's asking if a quiz on the 9th. Let me double check. If you do, I may have forgotten about it. Let's see here. When did I put your 3rd quiz? Let me look in the syllabus real quick. I apologize for slowing things down. Because I don't think I put it on the. I need to update the main page for the course. So I'll update that. But yes, you will have a quiz on the 9th. I'll let you know next week after what we cover to see what's going to be on it. So don't stress too much about that. So we'll have a quiz on the 9th. We'll meet the 16th, and then your test will be on the 22nd. So yeah, we're going to be wrapping up here. Before you know it, you'll be on rotations. Before you know it, it's pretty wild, pretty cool. Anyway, So we talked about diabetes, we talked about insulin, we talked about using short-acting versus long-acting, how you might use those differently, depending if you need sort of like basal control of glucose, if you need something kind of throughout the day for things like control postprandial hyperglycemia, things like that. So now I want to kind of switch gears here a little bit and talk about how we're going to use oral meds much more predominantly for type 2 diabetes, because of course the pathophysiology is different, right? Because with type 1 diabetics, typically they don't produce any insulin themselves, or very little. Whereas with type 2 diabetics, it's not a problem where they were unable to produce insulin. It's just they've been overworking the pancreas for so long that now it's become an issue where they have a lot of resistance. If my mic is too loud, let me know. I'm getting some peaks here, but if it sounds okay, just let me know that too. So anyway, so of course when we're treating patients with type 2 diabetes, we want to look at things like their preprandial glucose, you want to look at their fasting glucose, their A1C, all of that can be useful in kind of determining how effective your therapy is. And of course you may find patients who will come in the day of the visit and they have like a normal glucose level, but then you check their A1C and it's like super high, and it's because they'll take their meds the day of the visit when they're thinking about it, or they don't want to get the talk of shame from their provider, but then you realize they haven't been taking their meds, they haven't been compliant at least that past 3 months. So it's something you can certainly discuss with your patients. But primarily, with type 2 diabetes, it's usually has been brought on by, either a combination of like genetics, lifestyle decisions, things like that. If we can try to modify what we can, that's great. So if we can change their diet, if we can get them exercising, lose weight, all those kind of things are going to be certainly beneficial. And then we're going to see what sort of therapies we can use by themselves, like kind of monotherapy. And then if that's not working, then we're going to consider doing things like combo drugs. It's always ideal if you can use oral medications, but we're going to look at some of the newer ones that are intravenous, or not intravenous, that are usually injected sub-Q, and how those can be beneficial. And then if they still can't get controlled even with all of that, then that's when we're going to start to utilize insulin. And typically for those patients, you don't necessarily have to put them on like as strict of a regimen as you would a type 1 diabetic patient, because for these patients, you're not replacing what they're missing. You're trying to give them sort of an extra boost. And so for these type of patients, you may only start off with like a long-acting insulin, because again, they have like a baseline basal insulin resistance through all the time. So if you can use a long-acting, that can be beneficial. So you might start off with like a Levemir, insulin glargine. You might start off with insulin degludec, something like that. But you won't typically go with like the 3 times daily short-acting insulins around meals. That's going to be more difficult to treat patients. Hopefully, you don't have to get that far. The big challenge you find with these patients here is that they respond very differently in terms of like how much insulin they're going to be releasing, how much glucagon they're releasing, as compared to someone with normal glucose tolerance. That's that NGT. IGT is going to be someone with impaired glucose tolerance, or sort of on the path towards type 2 diabetes. And then you see someone who has flat out type 2 diabetes. Looking at their plasma glucose levels, you can see a comparison to that with their insulin. Someone with normal insulin resistance, like typical healthy patient, you'll see their insulin spikes after administration of glucose, and then it dips right back down because that glucose is being shuttled into the cells. You just don't, you don't need that much insulin. With resistance, you're going to see that those levels stay high, they get higher, and they stay higher for longer. And then as you develop type 2 diabetes, you're wearing out the pancreas. It just can't release as much insulin anymore, which is why sometimes they need that replacement. They need some additional boost by giving exogenous insulin. So you can kind of see the differences here. And if we can do anything to try to utilize our insulin more effectively, so if we can sensitize the body to insulin, that's going to be really beneficial. Or in some cases, try to help the pancreas to release more insulin. That can be some of the therapeutic modalities we can kind of go with. Additionally, what you can see here is that if you recall, glucagon is sort of the antagonist to insulin. And so if you have hyperglycemia, you shouldn't be releasing a lot of glucagon, right? Because you don't need it. Your blood sugar is fine. You don't need to be releasing glucose from the liver. What happens with someone with type 2 diabetes is you would see, whereas someone with normal glucose tolerance, if you were to give them a bolus of glucose, you'd see their insulin spike and then it drops back down. On the flip side, you see their glucagon drop down because their blood sugar is fine. They don't need it. Someone with type 2 diabetes, you're going to see, again, they don't have as big of a peak of insulin being released, but then also their glucagon stays high here. So they have this hyperglycemia that is also being sort of exacerbated by the glucagon levels, releasing more glucose from the liver and elsewhere. So that's kind of the big problem here we're going to look at, and some modalities we can use to try to suppress that if we can. Here are the major classes of drugs we're going to talk about. I'm going to get into their specific mechanisms as we go through, so you can just kind of refer back to this as we talk about the drugs. If you want to review this slide, that can be useful to try to compartmentalize where all the drugs sort of fit in terms of their mechanism and whatnot. I think I got most of you guys in here. You got 23, so it's pretty good. So just to kind of compare the different modalities here, you can kind of see what sort of expectations you have in terms of efficacy in treating patients with some of these therapies here. So these are some of the different classes which we're going to get into. If you have trouble saying words like thiazolidinedione, don't worry, everyone does. It took me a lot of time to practice that, but I'll give you some other ways we can talk about these drugs that are a little bit easier. But you can see the different classes, and again, I'm going to get into these very specifically. So drugs like your biguanides, like metformin, you can expect to see things like reductions of A1C about 1 to 2 points, which is really good. You can see their fasting plasma glucose drop down roughly 60 to 70 points, which again is really good. If I don't know if anyone's taught you this, but generally speaking, a point of your A1C change usually means about a 35 milligrams per deciliter change in your glucose. So that kind of comports with the 60 to 70s. You get that 1 to 2 point change there. So that kind of makes some sense. So first off, we're going to have our sulfonylureas. These are the first oral class we're going to talk about here. These are considered to be oral hypoglycemics. Basically, they're going to be helping the body to release more insulin. They have the first generation drugs, which we don't use quite as much anymore. They tend to cause some problems, which we're going to look at. But the second gen drugs you're going to see much more frequently. Probably the one out of the first gen you're going to see more often is chlorpropamide. And then you'll see a lot of the second gen drugs. You have things like lamepiride, you'll have glipizide, and then glyburide are the three main ones here. Most of them come as like an extended release sort of preparation there. The glucotrol XL is kind of neat because the pill itself actually has a tiny hole in it. Let me see if I can find a picture. And it's designed to slowly release the drug over the course as it travels through the GI tract. And so through that hole, little bits of drug will kind of seep out over time. And what's interesting is that patients will actually find that pill in their feces, and they'll think, "Oh, this drug isn't working. It's not even being absorbed." But it's how it's kind of designed is to have that tiny hole in it. I'm just trying to find side XL. Type a picture. Yeah, here's a good picture here. So let me switch over. So you can see that little tiny hole here. So they'll have the whole pill basically show up in their feces because this is not absorbable. But they'll have that tiny hole where the drug will actually seep out. So pretty cool design there. But you should educate your patients, because otherwise they may call you up or they'll call the pharmacy saying, "Hey, what the heck? This drug's not working," when really it is. If you look at their glucose. Anyway. Again, I find this stuff interesting, but maybe that's all subjective. Anyway, so looking at this, how the sulfonylureas are going to be working here, and if you recall how the beta cells work to stimulate release of insulin, it had to do with glucose being sucked into the cells, being converted to ATP, and then closing these potassium channels, which caused the cell to depolarize. That allowed voltage-gated calcium channels to open up, calcium flows in, and then that stimulates these little vesicles to fuse with the membrane and release insulin into the bloodstream. We can use sulfonylureas to directly cause those potassium channels to close, and then that will cause the same effect basically. So we're causing the pancreas to release more insulin by directly closing those channels, so we don't even need that glucose there in the first place. So it's kind of overriding the beta cells and causing them to release more insulin. So you can already maybe anticipate some of the side effects you might be able to see there as a result of that. Anything that is releasing more insulin or causing more insulin to be secreted can lead to things like hypoglycemia, can lead to things like weight gain and things like that. So, if you understand the mechanism, you probably understand a lot of the side effects that can come about from that as well. Other sort of ancillary things that you can see that are sort of secondary add-on effects of the drug include more insulin receptor sensitivity. You have lower glucagon levels. This is typically due to having more insulin, and then also somatostatin, which is an antagonist to glucagon, will also be released as well. But the main thing is closing these channels and directly causing the release of insulin. A lot of these are metabolized in the liver, and some even have some active metabolites, which may not be great if you have patients who can't clear it because they'll stick around for longer. And that can increase your risk for having hypoglycemia that can develop there. So again, be careful. And if you recall, insulin is cleared partially through the kidneys as well. So if they have renal impairment, they may also have trouble clearing that insulin that's being released as a result of the sulfonylureas. So that's something you may want to consider there. We will not use these in pregnant patients. This class is typically not recommended because it can cause depletion of insulin in the pancreas there for the fetus, which is not great, obviously. Some of the things you're going to run into include chlorpropamide being a little bit more commonly causing hypoglycemia, mainly due to the fact that it's so long acting, and you can have accumulation occurring in these elderly patients, which is not great. It can also cause a disulfiram reaction, just like we saw with metronidazole. So obviously you want to tell them not to consume it with alcohol. Remember, alcohol can also sort of increase the hypoglycemic effects of the sulfonylureas as well, so that's something to consider there. Alcohol is kind of a weird one because a lot of alcoholic drinks will contain a lot of carbohydrates depending on what their alcohol of choice is. So that may be a hit or miss sort of thing. But in general, alcohol tends to worsen hypoglycemia as a result of these. And glyburide and chlorpropamide tend to be the worst out of the bunch here in terms of causing that. And so again, some of the add-on effects we're seeing with these drugs, other than just releasing the insulin, is kind of some more better utilization of the insulin they are releasing. So you get more sensitivity and things like that. Just be careful if you ever mix these with a patient who's on insulin, because they will likely require a lower insulin dose because this is causing their pancreas to release more insulin. And again, that can also lead to some more hypoglycemia. So generally speaking, I don't see a lot of patients who are on a sulfonylurea plus an insulin, but it may happen occasionally. It's just something you have to kind of adjust for there in terms of adjusting their insulin dose. Again, you're going to see that the biggest side effect is going to be weight gain and hypoglycemia. So those are the two big things you want to worry about, especially if like kids get into this. I had a case just recently where a kid got into a glyburide, I believe it was, and they were requiring kind of multiple dextrose boluses in order to keep his blood sugar up. And it kind of stinks because it's a long-acting medication. So I mean, it's an automatic ICU stay for a lot of those kids because you're having to do so frequent glucose checks and having to give them glucose infusions and whatnot. So it's not ideal. So as I mentioned, hypoglycemia, weight gain, these are the two big ones. You can see some random other side effects, but these tend to be sort of more hit or miss and pretty rare for the most part. I can't say I've ever seen a case where I've seen someone develop aplastic anemia from one of these, but it's been reported. And then you can develop resistance over time, and this is mainly just due to the pancreas wearing out. Those beta cells just don't have any more insulin to release, like you saw in those graphs with the type 2 diabetic patients there. In terms of contraindications, obviously you probably don't want to give this to someone who has diabetic ketoacidosis because they don't have any insulin to release in the first place. So this would have no role for someone with type 1 diabetes, and then typically we don't like it for pregnancy. In terms of interactions, just be careful if you mix this with any other drugs that lower blood sugar, because this can increase your risk for hypoglycemia. If you combine this with drugs that increase glucose, then obviously they're going to be antagonizing one another. So if you give someone a corticosteroid that raises their glucose, this is going to make this drug less effective. As I mentioned with the chlorpropamide, just watch out for that alcohol interaction there. Obviously you should be having them be responsibly consuming alcohol, but they're going to have a much worse time if they're consuming that along with chlorpropamide. Up next, we have the meglitinides. These are very similar in terms of their actions to the sulfonylureas. There's just going to be one sort of primary difference. The two drugs that fit into this category include repaglinide and then nateglinide. These are basically doing the same thing as the sulfonylureas in terms of closing those potassium channels. The difference, though, is that the insulin release is relative to the glucose level. So if you have someone who has normal, relatively low blood sugar level, and you give them one of these meglitinides, it's not going to do anything to their blood sugar, presumably, or very little to their blood sugar, because these drugs to work require blood sugar to be high, like after a meal or something like that. As opposed to a sulfonylurea, if I give someone who has a normal to low blood sugar and I give them a sulfonylurea, that insulin release is going to be happening no matter what. And so that blood sugar is going to drop down even lower. That's kind of the big difference with these, and it also makes sense in terms of the timing that you probably only want to take this before meals when those glucose levels are going to be higher anyway. Honestly, I don't see a ton of use of these drugs here because most people will just go with the sulfonylureas, but you still want to be familiar with it in case you see a patient who's on it and you can identify, okay, yeah, that's an oral hypoglycemic. Typically between 10 and 30 minutes before a meal, because that's when the drugs are going to be most effective, is when you actually have glucose being ingested there. Most of the time you're going to see this mixed in with other medications. These are probably not going to be the primary drug you'll start a patient on, but it could be a useful add-on. And in fact, I'll give you a chart here at the end that will kind of go over all the different meds and how we sort of mix and match them. And so I'll talk about that later. But one thing to note here is if you miss a meal, then you just skip a dose because the drug's not really going to do anything for you at that point. So side effects are going to be very similar to the sulfonylureas, just probably a little bit less than, because they're not going to be quite as effective as the sulfonylureas there. So a little less insulin release, a little less hypoglycemia, less weight gain, but still it's pretty consistent with that. So next we have the biguanides, which is pretty like stock standard. This is the main drug you're going to start off with most patients when they first get diagnosed with type 2 diabetes. Sorry, did I miss a slide? That's kind of odd. Anyway, really the big thing here is metformin is going to be the only one we really use here in the US. There's some other ones elsewhere, but this is the main one. And so you can see this is like glucophage or glucophage XL. A lot of these come as XL formulations, so that helps out with the compliance and only taking it one time a day. And you'll find a lot of combo drugs that contain metformin because this is usually the backbone to the rest of their diabetic regimens, which we'll talk about why that is in here in just a little bit. So if you see, metformin plus glyburide or glipizide or rosiglitazone, all these drugs we're going to get into. And so if you ever see that, that's what they're doing, is try to kind of get two birds with one stone and increase compliance. So the biguanides, metformin in particular, what they're going to do for us is they basically help our insulin to work better. They don't directly cause the pancreas to release more insulin. It just helps out with whatever you're releasing to work that much better. So what's going to happen here is it's going to be able to suppress hepatic glucose production. It's going to help out and increase peripheral glucose uptake and utilization. So that's increasing your insulin sensitivity. And it will also decrease glucose absorption from the GI tract. So you have a little bit less glucose coming in. So because of that, you're going to see very limited hypoglycemia. You're not going to see really any weight gain associated with it because you're not releasing any more insulin than you would be otherwise. And if anything, you might see a little bit of weight loss. So that can be one benefit from that standpoint. So the kinetics here are kind of interesting because, even though the drug is not metabolized in the liver, we still want to be careful because hepatic disease is going to be a contraindication here. And it's going to be because of this lactic acid buildup that can happen, which I'll talk about in a moment. But the drug is mainly cleared by the kidneys, so you have to be really careful and not use this in patients with kidney disease. If you're familiar, and I think we'll talk about this in the nephro section coming up later, but if you have someone, for instance, who needs to go and get an imaging procedure done, like a CT with contrast, right? One of the big contraindications that you should be looking for are they on metformin? Because we're going to see that if you cause kidney injury as a result of the dye that you're using, that can lead to a lot of buildup of metformin. That can lead to some pretty nasty stuff, which we're going to see here in just a moment. But this is really good for patients who are obese because this can help out with their weight, especially if they have insulin resistance. You'll see this a lot in patients with things like PCOS, where they might have kind of a hyper they have issues in terms of insulin resistance, and so this is a good drug to kind of help out with that. So you'll see for a few different indications, but the big thing here is no weight gain. If anything, a little bit of weight loss, which is nice. Because again, a lot of diabetic patients tend to be overweight. In terms of side effects here, we're going to see that the GI stuff is the most common, and this is a very frequent complaint. A lot of reason why people may not want to take this anymore is because it just really tears up their stomach. You can use the XL formulation. That will help out. You can try to divvy up the dose. So if they should be on 1 gram during the day, you can split it up to 500 in the morning and in the evening, for instance. Meals may be able to help out with that. So a couple of different options that you have there. And then in terms of lactic acidosis, this is the life-threatening thing that can happen with metformin. And this is really going to be seen in elderly patients and those that have renal impairment. Basically, if you have this buildup of metformin, they are going to develop this lactic acidosis just due to some of the effects that metformin has in terms of oxygen utilization of some of the cells, but you're going to see this lactic acid buildup, and that can be potentially deadly. I've seen several cases of this where patients were on metformin for a long time. No one checked their renal function as things deteriorated over time. All of a sudden, they have this like massive wide anion gap metabolic acidosis. They couldn't recover and end up dying from it. You'll see this sometimes after patients get contrast or they have some other kind of kidney injury that's acute. You'll see this sometimes after surgery because you can have sort of transient decreases in renal blood flow that can lead to accumulation. So just be really careful. A lot of times what you'll see for patients who are coming in to the hospital that need surgery is they'll actually DC the metformin. And you would expect, if they're diabetic, their blood sugars should rise because the metformin is no longer there, but you can just give them insulin, right? So you can actually just switch them over to insulin while they're in the hospital and then put them back on their regimen once the surgery is over and they've recovered. So it's kind of the thing you'll see sometimes. You may put them on a sliding scale insulin regimen or something. The other thing you might want to watch out for is anemia. This can actually decrease B12 absorption, so you may want to make sure they are getting that supplemented either in the multivitamin or the diet or elsewhere. As I mentioned, renal disease is going to be the major contraindication here. So if their GFR is less than 30, cannot use metformin. Okay. Also, just make sure you're looking up any dose adjustments that happen if you have someone who's kind of heading that direction. So they're starting to get down to like the 60s. You may want to make sure that you may need to adjust that. We used to do it based off just their serum creatinine, but we now just use a GFR. That's good enough, right? Also, if they already have any existing metabolic acidosis or hypoxia, if they have hepatic disease, this is not going to be a good drug for them. And as I mentioned, you should stop it before surgery, and generally you're going to withhold it for about 48 hours or so. And again, during surgery, you can actually have a buildup of lactic acid just due to the surgery itself, I don't understand why the contrast dye causes renal impairment. Why are you preventing it with insulin? So you're not preventing with insulin. So what I'm saying is that if you had a patient who's on metformin and they come into the hospital and they need surgery, or if they're going to get contrast dye or anything that could be causing a lactic acidosis or causing a renal injury, you don't have to keep them on metformin. You could just switch them over to insulin, like a regular insulin on a sliding scale or something like that, and that will then correct their glucose. And then once they've recovered from the surgery, 48 hours after getting the dye, then you put them back on the metformin, and then they're back to normal basically. The reason why contrast dye can cause kidney injury, which I think I might touch on this in the nephro section, has to do with the osmolar content of it. If it's generally speaking, a lot of the older dyes were very hyperosmolar, which led to kidney injury in terms of like causing some fluid shifts and things like that. So it's called contrast-induced nephropathy, or CIN. So you can look that up and get more details on that if you like, but that's a pretty well-known thing. Some of the newer ones are less likely to cause that, but you still want to be really cautious if you have someone who needs contrast dye. If you can do the procedure without the contrast, that's ideal, but sometimes you just have to have it. So that's why we do that. That doesn't make sense, so let me know. All right, so up next, then we have the thiazolidinediones, or TZDs as a lot of people call them. This includes two main drugs, PHARMACODYNAMICS and then Rosiglitazone. Some people call these the glitazones, however you call it's fine, as long as you can keep the drug straight. We used to use troglitazone, but that was removed due to some liver issues, which again will come up here. This has a little bit of a different mechanism. You're going to see that this as an agonist for this peroxisome proliferator activated receptor gamma, otherwise known as PPAR gamma, which is what I generally call it. And this actually helps with transcription of insulin responsive genes, basically meaning that it will help out in increase transcription and translation of proteins that are going to be more responsive to insulin. So maybe you're going to get more glucose transporters put up on the cell surface. You're going to also see that things like lipid metabolism is going to be affected here. So interesting set of drugs just because the mechanism is pretty novel. And so you can see here you're going to get better peripheral uptake and utilization of glucose because the sensitivity is higher for insulin, and you should be seeing less hepatic glucose production. Keep in mind that it's going to take time to work because it's working at the site of the DNA to change transcription. So just like with corticosteroids, it takes some time to kick in. This may take 6 to 12 weeks before you really see full effect. Just be careful, especially if they have hepatic disease, because this is processed to the liver, and so you can see some issues there in terms of clearance. This is another set of drugs that typically does not cause much in the way of hypoglycemia. So again, that's another thing you want to kind of know for general use and then also for testing purposes is what is the risk for these drugs to cause hypoglycemia? The high, is it low? The chart I'll give at the end will sort of delineate that as well, so that should be pretty clear to you. One disease state you don't want to use these drugs in are going to be CHF, because you can actually cause some fluid retention leading to edema in some cases. So if they have heart failure, this could tip them over the edge and having an exacerbation. You may see some effects on the lipids here, so you can see maybe like an increase in HDL, but you may also see a little bit of increase in LDL. But the big thing is to monitor for liver function tests. Make sure you're doing it every 2 months at first for the first year or so. And then if you see their ALT rise about 3 times the upper limit of normal, then you need to consider stopping the drug at that point there. So again, something to be cautious about, especially if they have any pre-existing. One of the challenges with these drugs and why I see not as many people use them is because there's some concern about risk of death associated with these. And you can see, and again, I'm not going to bore you with all the p-values and all that, but if you sort of took all the studies together and combined them, you do see some association with death. And so kind of, and this is in particular with Rosiglitazone, so it got kind of a bad name there because obviously you don't want to give anything that might increase the risk of death for your patient, but that's why you don't see as much use of the glitazones anymore. But again, you may see it occasionally, still want to be familiar with the drugs. Up next is our alpha-glucosidase inhibitors. This includes 2 drugs, acarbose and miglatol. These are basically going to be inhibitors of the enzymes alpha amylase and glucosidase in the GI tract. So in the brush border, there's enzymes reside within those cells. And so if you inhibit that, you can't really break down more complex sugars into their more simple forms that can be absorbed. So you leave more glucose out in the GI tract. So you have less glucose coming in. That should obviously help out your blood sugar, and if anything, may help out with weight a little bit, not a ton though. The benefit with these drugs is they have very limited systemic effects or systemic activity, systemic exposure. So this can actually be good for patients who you may not want to have a lot of systemic exposure. For instance, like pregnant patients or something, that may be a good option for them. Miglatol, you still want to look at the liver function, but for the most part, it's not going to be all that too concerning because it's very limited in terms of absorption. You do want to take this with the first bite of meals because that's when glucose is coming in. That's when you want to help to prevent those enzymes from working there, so that way they can't absorb the glucose. These are generally not going to be used by themselves. This will typically be like an add-on or like an add-on with insulin or something like that to kind of help those other drugs work a little bit better. The problem with it, though, is like what happens to all that glucose, all those sugars you still have in the GI tract? Well, they're not being absorbed, so they're going to get digested by your little friends in your colon, right? So all your little bacteria, the normal flora are going to start to digest those, and they're going to, when you break down sugars, what do you get? Well, you get CO2 formed. And so you're going to see a lot of abdominal pain, cramping, and then flatulence is pretty common. So, I mentioned it could be good for like pregnant patients from a systemic exposure standpoint to the fetus, but, a lot of pregnant patients have, issues in terms of their GI tract, either, reflux and things like that. So this is not going to be well tolerated by most patients, and it will actually probably be why a lot of people don't like to use it. Okay. Other things you want to watch out for is if they have any sort of inflammatory bowel disease, any sort of ulceration, any sort of intestinal disease, you probably want to avoid these because, again, that extra kind of stress from having all that gas and things like that are just not going to be very good for those disease states. So I'd avoid that. So up next, we're going to talk about a newer set of drugs, relatively speaking, and this is going to be related to a set of hormones called the Incretins. And so the Incretins are something that are released when you have oral intake of glucose. This is kind of interesting because if you look here, you can see the white line is going to be for oral glucose ingestion, and then the blue line here is for IV glucose administration. And if you look, you can actually see that the plasma glucose would be pretty similar between the two. You get a little spike as you get the absorption or the administration of it, and then you'll see your insulin or the glucose levels go back down as insulin takes care of it. What happens though is in terms of incretins, it only really responds to oral glucose. So this is something you're going to see that is released just when you're ingesting food, basically. Why is that important? Well, because you're going to see that this has a huge effect on things like insulin release, on glucagon release. Satiety is going to be another big thing. So how full people feel and if they want to eat more can be affected by this. And the main incretin we're going to be dealing with is going to be glucagon like peptide 1 or GLP-1 is what we're going to be talking about here. And so you can see this will increase after mealtime glucose is ingested. So if their insulin or blood sugar goes above 90, that will trigger the release of GLP-1. And you're going to see this does several things. So one, it increases glucose-dependent insulin release from the pancreas. You get more insulin coming out. It's going to be decreasing gastric emptying and food intake. So it's going to be one, slowing down how much food is leaving the stomach or how quickly it's leaving, so you feel fuller because there's more stuff sitting there in your stomach, stretching it out. And it also stimulates the satiety center in the CNS and says, okay, I don't want to eat anymore. So all good things, right? And you're going to see the incretins are not going to be released as much, and you're going to have lower levels of them as patients develop type 2 diabetes. And so this is why you see a lot of excess glucagon sitting around in patients who are type 2 diabetics, because they don't have this GLP-1 to inhibit it. And so I'll show you some graphs of that in just a moment here. Also importantly, GLP-1 is metabolized by this enzyme called dipeptidyl peptidase 4 or DPP4. That'll be important for a class of drugs here in just a moment. As I mentioned, you're going to see in the brain's promoting satiety. We're going to reducing appetite, which is very helpful, especially if patients are overweight. You're going to see less glucagon secretion, and you're going to see more insulin release as well. So a lot of help here. Again, the stomach is going to help to regulate that gastric emptying and slowing it down. They feel fuller, they get fewer calories and less glucose coming in, and then they're able to process whatever glucose does get absorbed better because they have less glucagon and more insulin being released. Okay. So as I mentioned, with type 2 diabetic patients, you're going to find they have diminished levels of insulin as well as GLP-1. And that's probably why they have a lot more glucagon, or why their glucagon levels stay higher, even in response to them having glucose coming in through the GI tract, right? And so we're going to see here that by either replacing the GLP-1 with something similar, or by preventing its breakdown, we can try to help enhance the incretin effect that these type 2 diabetic patients are missing. And again, looking at the slide, again, this is why the glucose ends up staying so high, is because they just don't release as much GLP-1 anymore. Or if they do release any of it, it's getting broken down by that DPP4 enzyme. Okay. Here is a picture showing kind of the difference in GLP-1 release as compared between someone with normal glucose tolerance, impaired glucose tolerance, and type 2 diabetes. You can see here they just don't release nearly as much as someone with normal glucose tolerance. So if you can replace that, or if we can prevent the breakdown of what they're releasing, this can help to mitigate that effect. So first off, we have the incretins. We have the replacement drugs, which we can use to replace the GLP-1 that they have. So you may be wondering, like, why do I have a picture of a Gila monster sitting here on my slides? That seems odd. Well, this is another good example of a drug that comes from an animal source. And again, I always love to point out where things come from plant or animal sources. I find that really interesting when you can use things from the natural world to treat human patients. And so interestingly enough, the saliva of the Gila monster actually shares a lot of homology with GLP-1. And again, I don't know what evolutionary pathways led to there being similarity between the saliva of a Gila monster, protein-wise, and our GLP-1, but there you have it, right? And again, I don't know who the scientist was that was going through and testing different things and found that Gila monster spit happened to be the thing, but again, it sounds like a pretty fun job, I would imagine. But anyway, so the first drug we have here is Exenatide, or Byetta, and this is the first one we had out of this class here. We're going to see that this is the first, but probably not the best one out of the bunch, but it is still used occasionally. This is good for type 2 diabetic patients who are like on metformin and you want to add on an additional drug. This may be a good class to do that with. The problems with these is because it's a protein, you're going to see that it has to be injected. So this may be the first injectable drug these patients go on. This would be like a sub-Q injection they're going to use. So with this one, it wasn't ideal because this had to be twice daily sub-Q injections, which is not ideal. Obviously, if they can get them to they can use fewer injections. That'll always be better, especially if they're already taking insulin. But the benefit here is you're going to see a lot of weight loss associated with this. So you'll find that they just don't want to eat because their satiety center is being activated. And that can be very beneficial to a lot of these type 2 diabetic patients. And again, as you lose that weight, as you drop that weight, that will help out with the insulin resistance as well. So very effective, but also consider that it's protein based, so it's going to be a lot more expensive as well. So interestingly, you can see sort of the difference here. So this is like a healthy control patient who normally if you would see oral administration, actually, I'm sorry, here you see IV glucose, you see a big spike in their insulin and it goes back down. Is what you would normally see. If you have someone who is getting just placebo with type 2 diabetes, you can see here they don't really have as big of a spike versus with by giving the Exenatide to get a much better spike there of insulin. So again, really pretty helpful for these patients, really effective set of drugs, but twice daily injections, not ideal. Big things you're going to see here in terms of side effects include some nausea and vomiting. That makes sense because if you have more stuff sticking around the stomach, that could cause some backup and maybe some reflux there. So you're saying, are incretins like a last resort class for people who are already on metformin? No, they are not. I'll talk about their place here in just a little bit because that's a lot of the questions I can ask on an exam is saying, okay, someone's on metformin, what do you want to add on now? And it may be dependent on things like comorbid conditions, which may lead them to not want to be on certain medications, but I have a whole table that will kind of go over that. So I'm going to touch back on that in here in just a moment, Christina. So yeah, so you can see nausea and vomiting associated with that. You can see some hypoglycemia if you add it on with the sulfonylurea, but this is pretty rare for the most part. But you can see a delayed absorption of other oral medications. So you may need to like spread these out a little bit, depending on the situation there. The weight loss can be not a great thing if they don't need to lose weight. So I'll give you an example that hits close to home. I had an uncle who, and I'm not sure if you guys are familiar with the late actor Wilford Brimley. If not, you should find a picture of him. But he is famous for his diabetes commercials. He always talked about the testing supplies and things like that. But he was a staple on daytime television commercials growing up as a wee child. But anyway, so my uncle looked exactly like Wilford Brimley. He was overweight, had diabetes, but he actually ended up being put on one of these incretin mimetic drugs. And it was pretty wild because I think I saw him like at 4th of July and then I saw him at Thanksgiving. And during that time frame, he was like a shadow of himself. He had dropped all this weight. And I was like, man, what happened? What'd you do? And he said, well, I got put on one of these drugs here, inject myself, and I'll show you some of the other ones here, but he only had to do it once a week. I just didn't want to eat. So fewer calories in means your weight's you're going to drop some weight there. That can be a problem though, because he ended up actually in the hospital at one point because he was like basically malnourished because he didn't want to eat it all, and he was didn't have enough nutrients coming in, his electrolytes were all thrown off. So it can be a double-edged sword, right? So you may want to consider something like that depending on the weight of the patient you're dealing with, okay? Interestingly enough, this can also cause pancreatitis, maybe kind of putting extra stress on the pancreas, but this is something you may see. And again, that weight loss thing may be like an off-label use, but it may not be something that insurance companies want to pay for. So that can be something you might see done on more of an off-label sort of case there. The other incretins that are out now are a lot better from a administration standpoint. So instead of giving yourself twice daily injections here, you have liraglutide, dulaglutide, and then albiglutide. The last two here, you're only injecting once weekly, which is pretty ideal from that standpoint. On the other hand, though, you'll see something like liraglutide, I think it's only dosed one time daily. But again, if I had a choice between injecting myself once a day or once a week, I'd probably go with the once weekly if I could, for sure. On the flip side, so instead of replacing what they're missing, we can try to help and prevent the breakdown of what they already have. And so this is where we have the dipeptidyl peptidase 4 inhibitors, or the DPP4 inhibitors. And basically these help to prevent the breakdown of several different incretins, including GLP-1, which is the main one we're going to be focusing on here. They also, interestingly, are involved in some T cell activation, but that's not really going to be pertinent to our purposes here. The main drugs in this category include allogliptin, sitagliptin, saxagliptin, and then linagliptin. So obviously you can tell how to identify those just based off their names there. Biggest things to watch out for include angioedema and allergic reactions. They can also develop Stevens-Johnson, so that's something to note there as well, sort of unique to this particular class here. And you can see that the gliptins are actually really helpful to use as an add-on drug. So you see some synergy here as an example of reduction in A1C between just either of these drugs by themselves versus adding on the combo. So again, synergy is used very frequently in these type 2 diabetic patients here. And shame on them, they use QD. You're not supposed to use QD. That's an unapproved abbreviation, right? Looking at the comparison between the GLP-1 agonist and the DPP-4 inhibitors, you're going to see that both help out with insulin secretion, both reduce glucagon. Overall, you're going to find that the incretin mimetics are overall more effective than the DPP-4 inhibitors. So you're probably going to see a bigger drop in their A1C than you would with the DPP-4 inhibitors. The other big thing here too is that you're not really going to get much in terms of weight loss with the DPP-4 inhibitors. That's really just on the GLP-1 agonist side, much more effective for that. However, the gliptins are going to be orally administered, so that can be a benefit if patients are really needle phobic or they didn't want to use an injectable dosage form. And this antibody formation, this is something that can come up for patients on the GLP-1 agonist, mainly because it is a foreign protein, so there is a risk for having some allergic reactions from that standpoint. And then in terms of unique side effects here, pancreatitis with the GLP-1 agonist is going to be more unique to that group versus Stevens-Johnson's for the gliptin drugs there. All right. And then finally, we have the newest set of drugs used for diabetes is the sodium glucose cotransporter 2 inhibitors. And again, they make these names so catchy. The SGLT2 inhibitors. So 3 drugs in this category so far. As I mentioned, this is the newest out of the bunch here, but we have canagliflozin, we have dapagliflozin, and then empagliflozin. These are new enough. These weren't even available when I was in school, if that kind of gives you any kind of idea in terms of time frame. But what these drugs do is that if you were to look at the kidneys and kind of what's happening as blood filters through the glomerulus, you will see that you do filter glucose just fine through the glomerulus, but most of that does get reabsorbed in the proximal convoluted tubule, right? Ideally, type 2 diabetic patients you're going to find may not be able to do that because they can overwhelm the transporters and they will just pee out that glucose, which is why you would see that on like a UA for someone type 2 diabetes potentially. These drugs are going to inhibit that reuptake. They're going to inhibit that reabsorption of glucose in the PCT, the proximal convoluted tubule, and they're just going to pee out that extra glucose, right? So as you might imagine, if they're eliminating all this extra glucose, that could be good from like a weight loss perspective because they're not holding on to all those carbohydrates. Be good. We're also going to see some other issues because it's not just people that love sugar, but it's like everything loves sugar. Plants love sugar, bacteria love sugar, fungus loves sugar for sure. So we're going to see there's some issues with that in just a second here, which is this second. You can see here, urinary tract fungal infections are relatively common. Like 1 in 10 patients are going to be able to see this. And again, that's not something high under differential when you see someone with a UTI, right? You're not going to think in fungus right away. But if you had this history of them being on one of these SGLT2 inhibitors and they come with a UTI, this should be much higher on your index of suspicion, right? And again, patients with diabetes are already going to be more likely to have UTIs anyway, just due to the fact that they have all this extra glucose being spilled out in the urine there. Other things you can see is that you will find sort of a diuresis sort of effect because all this extra glucose in the renal tubules will draw some water along with it, and that can lead to decreased blood volume and hypotension that can develop here. You want to watch out for that, and they can cause some kidney injury. So this is not be good for patients with like renal disease. And interestingly enough, this also has some effects on bone resorption and fracture risk. So if you had a patient, this is particularly seen with canagliflozin, but this is something where if they had a history of like osteoporosis, I'd probably steer clear of this set of drugs, just as an example. This can also cause, interestingly, and this is unique to this, a euglycemic diabetic ketoacidosis. And so, again, I've not seen this personally, but it's been reported where it kind of makes sense that they're euglycemic because if they don't have enough glucose to utilize in the cells because they're peeing it all out, then you wouldn't measure really high glucose levels because it's all coming out in the urine there. So it's kind of a unique, rare sort of side effect you can see with these drugs in particular. So this is that slide I was talking about that kind of gives you an idea of how to mix and match these different drugs for type 2 diabetes. So kind of walking you through this, you'll see the drug class at the top. You're going to see their effect on A1C. So if they have a high, low, or medium ability to drop A1C, obviously the higher the better. We're going to see their risk for hypoglycemia, because that is certainly something that can be deadly if not caught and managed. The effect on weight, which is more sort of like on a long-term sort of thing, because more long-term concern, because a lot of these patients are overweight to begin with. We'll look at side effects, and then we'll look at the cost. So kind of all the main things you want to think about when trying to pick one drug versus another, right? The side effects are the ones that are kind of particularly unique to this particular class, okay? So most patients without a contraindication are going to start off with metformin because it's cheap. We have a lot of experience with it. It's relatively effective for what it does. Other than the GI effects, and they got good kidneys, is a good drug to start with, okay? After that, if you see that their A1C goal has not really been reached, then you can add on another drug. So again, this is metformin plus something else, not metformin, and then switch them to a different class altogether. This is an add-on sort of thing, as long as they're still tolerating the metformin. And so look at the differences between these classes here to kind of decide what drug is going to be kind of best for your patient. So a sulfonylurea, it's going to have a higher risk for hypoglycemia than something like metformin. So that could be a concern if they are prone to hypoglycemia. Weight gain, if they're overweight, this might not be the best class for them. But it's low cost, so this is a relatively easy thing to get a hold of for most patients. They can usually afford a sulfonylurea because they're old, they've been around for a long time. So there's generics and things like that available. So kind of go through and look to see, okay, what are the risks here, and kind of get an idea for what kind of test questions I could write based off of contraindications, comorbid conditions, what drugs are already on, things like that. Okay. And again, it sounds like the GLP-1 agonist would be like a really good thing to add on. And so to go back to your question, Christine, this wouldn't be a last line, but again, you would want to use it selectively. So if I had someone who was diabetic, but they're relatively normal weight or thin, like maybe a GLP-1 agonist is not going to be the best bet for them, right? Or if they had a history of recurrent UTIs, that might not be the best bet for them either. If they can't afford the GLP-1 agonist, that's obviously going to be an automatic no for that, because if they can't afford the drug, they're not going to get it. They're obviously not going to take it. But it's perfectly fine to add on. It's not a last resort at all, for sure. At that point, if you still have not been able to reach your goals here after 3 months, which is kind of that time it takes to kind of re-equilibrate your A1C, then you can consider a triple therapy. And again, which one you pick is going to be very much based off of what other class are they already on. Obviously, you don't want to use two of the same class. What, again, comorbid conditions, all this type of things you're considering. At this point is also when we consider adding on insulin. Usually they'll be on a long-acting insulin like a Degludec, a Levemir, something like that. Usually once in the morning, and then that will kind of cover them throughout the day, but you still keep them on their oral meds for the most part. And then if they're still not being able to reach their goals there, then they may just have to go on a basal bolus sort of regimen, just like you would with a type 1 patient. So that's kind of the thing there. And if you have questions, about how you might use one drug class versus another, just let me know and I can kind of go over that. Any questions for that section? If not, I'm going to continue on. So I think the last thing I want to talk about here is thyroid pharmacology. So some meds we can use to both help and hinder the thyroid gland. So we can have either problem here with these patients. We can have hyposecretion, we can have hypersecretion of thyroid hormone. Recall that predominantly our thyroid gland releases T3 and T4. T3 is the active form, T4 is going to be sort of like the storage form. It has to be converted to T3 before it becomes active. And again, this can be an issue if you're looking at the whole axis here. It can be a primary problem where the gland is maybe not producing hormone for some reason, maybe a lack of precursor, maybe they don't have the gland anymore. That could be one reason they're hypothyroid. There can be a secondary problem where the pituitary gland is at issue, and it can be a tertiary problem when the hypothalamus is going to be the problem there. Basically, if they have a hyposecretion issue, you just replace the hormone, right? You can give them hormone replacement, that's fine. So we'll talk about some ways we can do that. they're having hypersecretion, there's a couple things we can do there. And again, this can be a problem where they can develop, sort of like hypermetabolic state. They can get hypertensive, they can get tachycardic, and then you can develop what they call thyroid toxicosis or thyroid storm in some very severe cases. They get hyperthermic and they're really anxious, and it doesn't look good. And so there's a few things we can do from that standpoint too. So we'll talk about some ways we can try to lower thyroid hormone levels in patients. And here's kind of what this looks like. Again, you'll find that the hypothalamus is going to be releasing thyrotropin releasing hormone, or TRH, onto the anterior pituitary, and then that will then release TSH, or thyroid stimulating hormone, onto the thyroid gland, which will then release T3 and T4. That has a negative feedback loop associated with it, so as T3 and T4 levels rise, they should feedback and inhibit release of TRH and TSH, which is why when someone comes in with hypothyroidism, you'll find their TSH is high, whereas their T3 and T4 are low. Once you replace that, then their TSH should come down, right? Also find things like iodide can be either a help or a hindrance, depending on the level that we're shooting for here. So what's the process for how we produce thyroid hormone? Because if you understand that, then you can kind of understand where some of the drugs are going to be working at here. And this is kind of the process. And again, I apologize if anyone's a chemistry snob and I get iodine and iodide mixed up. I always do it. I can never remember. So please forgive me for that. If you take umbrage with that, you can always bag me in my reviews, but otherwise. So again, iodide is going to be a very important precursor to thyroid hormone. If you don't have iodide, guess what? You cannot produce thyroid hormone. So you have to have some. In most developed nations, this is not a problem. We get a lot of it in our diet. Foods may come fortified with iodide. It's generally not an issue. In other developing countries, though, this can be a problem. So you can see these deficiencies. And again, when the thyroid wants to produce T3 and T4, but it can't because of lack of precursor, that's when they can get those goiters that can form there. So you can see those really sad pictures of kids in developing countries that have these massive necks because they can't get enough iodide in their diet. But anyway, so what we're going to see here is iodine is going to come into the thyroid gland, to these follicular cells. There's going to be this process called iodination, where you're going to find this peroxidase enzyme will convert the iodine into iodide, or vice versa, whatever. I'm not going to quiz you on that. And it gets combined with tyrosine. It's called this organification process, where you're combining a metal with an organic molecule like tyrosine, and you're going to be able to get some of the precursors to T3 and T4. There's kind of two things here: monoiodotyrosine and diiodotyrosine. Obviously, the difference just being how many iodides are added on. And that's where they can then combine those two together to get T3 and T4. I'll show you a picture of what this looks like in just a second. But if you have one diiodotyrosine plus one monoiodotyrosine, that's 3 iodines. That's T3. If you have 2 diiodotyrosines put together, that's T4, because now it's 4 iodides. So that's just a handy way to remember that. It can then be reabsorbed. It'll undergo this thing called proteolysis, and then T3 and T4 will then be released into the bloodstream. T3 being the active form, they can get down to the nucleus to do things like gene transcription and affect metabolism and all of that. T4 is going to be more so on the sort of storage sort of side. It just kind of floats around until it's needed, and then it'll be converted over to T3 and when it's in the active form. So this is just kind of talking about that step there. So again, you get this iodide trapping, where it's going to be coming into the cell and then gets converted to iodine. So this peroxidation step. Again, there's different ways you can affect this. So for instance, having really high levels of iodide actually prevents this from happening. So it's kind of the kind of seems kind of oxymoronic a little bit, that having iodide is important for producing thyroid hormone, but having too much is going to lead to actually hypothyroidism. You can have too much of a good thing. Actually, it's kind of interesting because that can be beneficial in some cases. Like actually, I'll talk about a pretty specific event that may occur in the future. Who knows that this may be useful to us. I'll talk about that later. But again, I'll undergo that organification step, and that's when it's going to be able to form T3 and T4 basically after it forms this mono and diiodotyrosine. So once they come together, they can then be released, and then generally in the blood, you're going to have about a 5-to-1 ratio of T4 to T3. So generally you don't make as much T3, but that's going to be the main active form, as I've already kind of mentioned there. And again, you kind of refer back to this slide to see how the process is going. The only reason why I kind of go into detail on the formation of the hormone is because it's important to know where you can kind of help and hinder the process if you have someone who has too much or too little thyroid hormone. Okay. And again, this is a slow process. This is not something you're going to be able to fix right away for the most part. And that it's fine because there's very rare instances where you have to fix the thyroid problem right now. And so again, this is generally a slow thing. It'll generally be 6 to 8 weeks between when you start a patient on a med and when you have them come back in to check to see what their levels are doing. So, am I just repeating the slides here? So as I mentioned, you're going to find that having high levels of iodine is going to be one way to inhibit this, and that's actually something we can do therapeutically. So I'll show you some options we have for that just a little bit later on. What can happen here is also kind of interesting. You can form an inactive form of thyroid hormone. So if you actually remove the wrong iodine, you get like this thing called reverse T3, and that's actually inactive. It doesn't really do anything for us. So here's an example. If you had like a T4 molecule, so you notice the 4 iodine, if you remove the wrong one, you end up getting this reverse T3 that doesn't physiologically do anything. This is the actual active form, the T3 that actually interacts with our nuclei and can cause all the good effects we're looking for, like increased metabolism and things like that. So let's talk about the replacements. Get into the actual drugs here. Primarily, you're going to find one drug used here, but there's a few others that are available that you may want to at least be somewhat familiar with. First off is levothyroxine or Synthroid. I'm sure most people have probably heard of Synthroid before. This is generally our treatment of choice, and this is just pure T4. Okay. Now you may be saying, okay, well, why are we giving T4? Shouldn't you give T3? Won't that act faster? That's true, that will act faster, but generally we don't really need it to act any faster. This is a slow thing we can fix. It's not something we got to fix right now. So it also provides more kind of consistent effect when you're able to give the T4. It's able to then convert it to T3 as needed. It works pretty well, but it does take some time to kick in. And as an example, if I have like a kid who calls into the or not, I guess the kid wouldn't call him, but let's say the parent calls in about a kid, calls to the poison center and says, oh my goodness, my kid ate all 30, my month's supply of levothyroxine. What's going to happen? Actually, the answer is like right away, nothing. Like it takes a week before that stuff will convert over. So we actually will set a follow-up to call them back in about a week, to see how the kid's doing at that point, or have them go into the physician at that point, because it just is not going to be that fast acting. Things you want to be careful for here are the fact that the absorption can be a little bit variable, and this is frequently dependent on what's being consumed with. So you have to really make sure you're avoiding things like iron, calcium, any kind of metals can chelate to it and prevent it from being absorbed, which is not great. Drugs that are inducing P450 enzymes can enhance the excretion of it, so again, that can lead to lower levels. But for the most part, this is used to try to get those TSH levels down. Can help to replace the T3 that you're missing, because it can eventually be converted over into T3. You could give just the active T3, and that's called liothyronine, but we're going to see that that's not done quite as frequently. If you needed a quicker onset, this would be something better to use, but it's higher cost, and honestly, I don't really ever see it being used that frequently. There is one that is kind of more similar to our natural ratio. This is called Liatrix or Thyrolar. This is a 4-to-1 ratio of T4 to T3. Some people like the more natural sort of balance there. I don't know any particular need for it, but like I mentioned, most people tend to be just fine on Synthroid. What are we using this for? Well, hypothyroidism, so Hashimoto's, if they've had a thyroidectomy, if they've had a radioiodine ablation of thyroid. This is something where if you had someone with thyroid cancer, you could actually use radioactive iodine to ablate the thyroid. So iodine primarily gets absorbed and concentrates in the thyroid gland. So if you were to give a radioactive form of iodide, like iodine 131, this is kind of the main one you'll see used, it will actually accumulate in the thyroid gland and release all those little beta and gamma particles and whatnot, and that will then kill the thyroid gland off. It'll just kill all those cells. And so if you do that, obviously they're not going to be producing any more T3 and T4, so you got to replace that, and that's where you can use Synthroid. So you may have patients who are on Synthroid for life because they just don't have a thyroid gland anymore. So the mechanism of the drug, is just the same as any other hormone. It's going to get down to the side of the nucleus. It's going to then be able to change things like transcription factors and whatnot, and help to overall increase metabolism, increase temperature, increase energy, all that sort of thing that you would see with someone who has had euthyroid, someone who's at a normal functioning thyroid, normal levels of T3 and T4. So pretty simple from that standpoint. Now, what can I do to reduce levels of thyroid hormone? How can I try to prevent someone from producing as much hormones. A couple of things you can do. Generally, you're not going to be able to restrict their iodide intake. It would be kind of difficult because most foods have some of it in there, especially a lot of like cereals and stuff are going to be fortified with that. But we have two things that can help us to prevent production in the thyroid gland itself. So we have propylthiouracil, which is PTU, and then we have methimazole. So these drugs here are going to be able to prevent the production of T3 and T4, and I'll show you kind of where that works at in the process there. In terms of complications, there's a rare case of agranulocytosis that can occur here, which obviously can lead to life-threatening infections. So the CBC might be something you want to monitor when putting patients on these drugs here. What they're going to do is actually interrupt the oxidation step of the iodine. So if you can't convert iodine into iodine, and if you can't organify it by adding on to tyrosine, then you can't form T3 and T4. And so the other thing too is that these drugs don't work fast either, because your body already has existing levels of T3 and T4. This doesn't do anything to those. The thyroid gland may have some additional precursor molecules floating around that this is not going to do anything to, right? Once that organification step has already occurred, these drugs don't do anything to that. But similar to how warfarin doesn't work on existing clotting factors but helps prevent the production of new ones, these drugs do the same thing basically. They prevent the production of new thyroid hormones, so they do take a while to work. Most things with the thyroid is going to be kind of slow acting. It's more of a marathon and not a race, so to speak. What do we use this for? Mainly for things like Graves' disease. They have like goiter and things like that. This can be helpful in order to help kind of shrink the gland prior to surgery potentially. This is where you're going to see it used most frequently. So the thing I was going to kind of talking about is interesting with iodine and how it can inhibit the formation of new thyroid hormone, is that we can actually do that on purpose in some cases. So just a little survival information in case you're curious, is if you were ever in a nuclear blast, or not, I guess they're not in the blast itself, you'd probably be dead. But let's say a nuclear explosion happened, and then you were surviving in the fallout afterwards. If anyone's a fan of the games, you probably know what I'm talking about. But one of the big things you have to worry about if you're in a post-nuclear sort of event is you have to worry about radioactive iodine, because it's really common in those kind of events. So radioactive iodine 131 is a big one. If you were just kind of passively breathing that in, that will accumulate in your thyroid gland and will kill it. And so then now you got hypothyroidism. You kind of need thyroid hormone around for survival purposes. So one of the things you'll see in a lot of like doomsday preppers and people's bug out bags and stuff is they will have iodine supplements on hand. And so you're taking kind of super therapeutic amounts of iodine in order to suppress the thyroid gland, so that way it's not taking up all that radioactive stuff. You'll just pass it out, and then you can save your thyroid. So hopefully we'll never be in that event, but if you're ever curious, that's why you'll see a lot of times in bug out bags and stuff, you'll have iodine tablets and whatnot, because that'll be really important for that. Again, useless knowledge. Another thing you can add on to your things to wow your friends with when you go to talk to them. Let's see here. So it's 9:05. I think I'm gonna get started on the next section. David, you don't have to lie to me. It's okay. I understand. Let's see. There's no questions here on the board. This is a lot of slides, and we have how many sessions left? At 3. We got that quiz. Kind of a big topic. Yeah, I think I'm gonna go ahead and get started on this. So if you guys don't mind bearing with me, I might even have time to do. We'll see. I don't want to make any promises right now, but we'll see what we can get through. Okay, so let's start talking about the kidneys and some issues you can run into. So we're going to kind of talk about chronic kidney disease. We'll kind of touch on acute kidney injuries as well. Some ways we can maybe try to prevent that. And then this section will follow up with urology, where we'll talk about things like erectile dysfunction. We'll talk about things like incontinence, BPH, all that sort of stuff there. So it's kind of a meaty topic here, which is why I kind of want to get started on, just to make sure I have enough time to sort of finish everything for you all and not try to rush it all at the end there. But anyways, I'll probably may go to like, we'll see where I finish up. But anyways, let's talk about chronic kidney disease. This is something you're going to run into in a lot of patients. You're going to see this quite frequently in patients, especially that are elderly. You're going to see this everywhere. And again, you can kind of define this based off of what their GFR is, which is we're using creatinine clearance as a surrogate for GFR in most cases. And so you can see as their creatinine clearance drops, you're getting kind of more progressive stages of CKD, which kind of makes sense, all the way down to where you can have, end-stage renal disease where they have a GFR less than 15. I mean, sometimes you'll get a creatinine clearance calculated that's like 2. That's just 2 mLs a minute. Like, that's all they can process through. So it's almost nothing. And these patients can be pretty challenging because a lot of medications have to be adjusted for this. There's a lot of metabolic consequences of chronic kidney disease. These are really complicated patients, especially when they get put on dialysis and things like that. So knowing how to handle these patients and being able to kind of follow up and deal with a lot of these complications is very important for their well-being. And again, a lot of times you'll see elderly patients don't get followed for their kidney function, or they just haven't been like checked in a long time, and you can see pretty significant declines. And if you don't go back and address that with their meds and other therapies, you can really run into a lot of problems. Like I don't know if I've mentioned this story, but I had a lady who was on theophylline for COPD, and she was probably 85 years old, and she comes in with intractable seizures because she got dehydrated, had sort of chronic kidney disease with an acute injury on top of that because she got dehydrated and sick. And it just, she died from that. We couldn't stop the seizures because she had such high levels of theophylline built up in the brain as a result of her chronic kidney disease. It's kind of an acute on chronic kidney issue that had happened there. So this is why we want to be really watchful for these patients. And so this kind of is a good follow-up to the diabetes talk, because this is a big leading cause of that, because we know that having chronic hyperglycemia tends to shred the glomeruli, just makes it, just does a lot of stress on the kidney. And so hypertension will be usually comorbidity that's going to help to hasten that. And even things like glomerulonephritis may be a more less common one, but can still happen. And certainly we know things like obesity, proteinuria, smoking, all of this can certainly be risk factors for kind of that progressive kidney disease. And short of a transplant, we can't really reverse that, right? So, and oftentimes, we have 2 kidneys, so they can provide a lot of, they can cover up for a lot of damage being done over time. But once you already start to see that decline in creatinine clearance, it's usually, you've already done quite a bit of damage to the kidneys by that point. So if we can stop some of these and prevent progression of further kidney injury, that is going to be good, because it's hard to reverse it other than just, giving them a whole replacement, which is not feasible in a lot of cases. And so you're going to find these patients will have, these progressive nephropathies that occur. They're going to be spilling out protein in the urine. They're going to have loss of nephron mass, this glomerular capillary hypertension, which puts a lot of stress there on the glomerulus. It just wears it out over time, which is not great. And so I want to talk about some of the chronic sort of conditions they have to go along with it, because you may think like, okay, well, they have kidney disease, but also they have anemia. I was like, why do they have anemia if they have kidney disease? Well, it's pretty intrinsic, as we're going to see here. So a lot of complications, a lot of consequences of this chronic kidney disease. So anemia is pretty common in these patients, mainly because they don't replace, or they don't have enough erythropoietin, which is mainly released from the kidneys. So they may have enough stores around of things like iron and whatnot to be able to produce hemoglobin and produce red blood cells, but they don't have that stimulus to make it, right? They don't have that signal to make it, which is because they don't have enough erythropoietin. We're going to find that we can actually replace that, and I'll get into the drugs here in just a little bit. But a lot of reasons why patients may also have anemia include things like if they have decreased GI uptake of iron, they may not be able to produce as much hemoglobin. They get a lot of frequent blood testing, especially if they're going in for dialysis, and that RRT stands for renal replacement therapy. So that may be hemodialysis, maybe peritoneal dialysis, but there's blood loss associated with that. And as I mentioned, you're going to be seeing that they're going to have overall increased demands for both iron and for erythropoietic stimulating agents. Okay, and this is one of the main reasons for their resistance, is because they don't either have enough stimulant erythropoietic. They don't have enough stimulus for erythropoiesis, or they don't have enough iron. We'll talk about some of the challenges there in just a little bit. They also have a lot of bone and mineral related diseases, and there's something called renal osteodystrophy that can occur with these patients, and it has to do with the parathyroid gland. It has to do with parathyroid hormone. It has to do with calcium, phosphorus, and vitamin D are kind of the big players here. And so I think I have another slide, but yeah, so basically what we're going to be seeing, and I'll kind of go back to some of these points here in just a little bit, but basically what happens in these patients is they have decreased renal function, right? So you start to have a decline in your renal function, and so that means you can't clear phosphate as well, okay? So you're holding on to more phosphate, maybe develop a hyperphosphatemia. That leads to lower calcium, and you're like, well, why does a high phosphate lead to low calcium? It's because Calcium and phosphate love to bind together. They love to bind together, and then that precipitates out. It's not very soluble in water. See if I can find a picture. Calcium and phosphate. Let's see if I can find out like a picture of this or a GIF or something I can show you guys. Because actually it is kind of interesting to see what happens when they combine together. But basically they precipitate out, and this can occur in the tissues too. So you can have these like tissue calcifications that occur here because of the fact that they just love to bind together. So this is kind of a picture, I think, that illustrates that. You can see how they just don't stick into solution. So that can be a problem like with drug administration, where you actually have like IV lines that are going to be lost because this calcifies over, or this can occur in the tissues too, which is not ideal. So what we end up running into is that we're going to have low calcium now, okay? Also, because we have low calcium, that leads to increased parathyroid hormone, because that's what is the primary thing that parathyroid hormone is looking for, is calcium. So, okay, well, we need to get more calcium in the blood here. So it's going to try to do that from a couple places. It's going to try to increase absorption from the GI tract. It's going to try to increase reabsorption from the kidneys, but it also affects phosphate. So you're going to be holding on to more phosphate and calcium. And then it also tries to get it from the bone. So we're going to see more mobilization of calcium from the bone. And then we're going to see that that can lead to things like osteoporosis, right? And you're also going to find that patients cannot form active vitamin D. So normally vitamin D that you get in from your diet is either things like ergo or cholecalciferol. You can form some precursor, some vitamin D from sun exposure, being here in sunny Florida. But that's not the active form. You have to be able to convert it. It takes a two-step process, both in the liver, which is the first hydroxylation step that occurs there, and then in the kidneys. So if you have poor kidney function, you cannot form the active form of vitamin D, which is also something the parathyroid is looking for. If the parathyroids detect low vitamin D, it's going to also release more parathyroid hormone. So we're going to see there's kind of a sick cycle that happens here, because as you sort of get more parathyroid hormone, you're going to be mobilizing more calcium, but if you can't clear it, you're going to see buildup of calcium and phosphates. You see more calcifications that occur, and it's a very progressive sort of thing. So we need to find some way to try to get in here and try to interrupt that cycle, so that way they can have good bone mineral density. They're not going to be at risk for fractures, and also they have good vitamin D levels, so they can absorb what they need to. So we're going to see a lot of issues with that. We're going to see some different ways we can try to manage that in terms of managing their calcium and phosphate levels and all of that. And again, you can see here, if you're destroying the bone, this also can lead to decreased erythropoiesis, which we already saw is a problem for these patients. So not great, right? So we're going to find some ways we can try to deal with that in a little bit here. So our goal for these patients is to try to delay or prevent progression. So we're looking at some drugs that they can be on that can sort of help save as much kidney function as possible, which is going to be ideal. And then we're also going to try to do some things where we can try to minimize any of the complications here. So as I mentioned, these are pretty complicated patients, and their medication list can get fairly intense in terms of all the different medications they're on, and some are interacting with one another, so we'll get some options for that. We'd also like to limit the need for hemodialysis, peritoneal dialysis, or transplant if at all possible, because hemodialysis, once they go on that can be really tough. They're typically on like 4-hour sessions 3 times a week. So that is like just your life. You're just going to dialysis 3 times a week for 4 hours. And that's doing anything 4 hours 3 times a week. That's a big chunk of your time. Pretty disruptive to your typical lifestyle. Peritoneal dialysis is a little less invasive, but I'll talk about that just briefly here. And again, try to address the primary cause. Is it because they're hypertensive, diabetic? Treat that. That's going to help to save some kidney function if at all possible. So that's going to be ideal. So first off, the thing we can do for these patients is try to fix their diet. We can do non-pharmacologic stuff. That's going to be ideal. And so we want to limit their protein intake, basically, because by doing that, that's also going to help to prevent things like proteinuria. It's also going to help to decrease their phosphate intake. And again, these patients typically have too much phosphate. What causes patients to get exhausted from dialysis? Do you mean exhausted like in the general sense of like I just don't want to go do it, or they just feel fatigued after dialysis? I guess this can kind of be two different things there, because we'd see some patients, and you see this a lot in the ER. You typically get these patients in on Sunday night, Monday morning, where basically they skipped they're just kind of sick of going dialysis, and they skip their Friday dialysis session, They said, I got other stuff I want to do, and they said, I'm not going to do it, or they get fed up with having to go to dialysis all the time, and they end up coming, basically coming into the ER with a potassium of 7 because they can't clear it, and they're just sick as snot, Yeah, so I mean, just having to do that 3 times a week, like the fatigue and not wanting to do anything after that. So I mean, like I could imagine too. I mean, imagine yanking all the blood out of your body and cycling and putting them back in. I mean, that could be a pretty fatiguing process, I imagine. But other than that, too, consider that these patients are typically anemic, right? And so if they don't have enough hemoglobin to carry oxygen to their tissues, you're going to feel fatigued. Other than that, I don't know of anything specific and why, but yeah, it's just, you're sitting there for 4 hours, having your blood taken out of you and put back in. It's just, can be kind of, I imagine, can be kind of exhausting, but I think the anemia is probably also to play there as well, because you will lose some blood in that circuit. So again, it's just a common thing to see that anemia there, but. It probably doesn't answer your question, but if you talk to someone, maybe a nephrologist, or maybe someone who works in dialysis, maybe they would know a little bit more than that. My main use of dialysis is more so like in the acute setting. So like for instance, I will recommend dialysis for like some of my patients that get consulted on from a toxicology standpoint. So I'll talk about dialysis briefly here in a little bit, but we can actually pull some toxins off of the body with dialysis. So if I had someone who had like a severe aspirin overdose or a lithium overdose or something like that, I may make the recommendation to dialyze the patient in order to pull that off to kind of expedite their recovery. It's not a decision you make lightly, but it's something sometimes we have to use. You'll see using the ICU setting and whatnot, but these patients are more like on the chronic Monday, Wednesday, Friday sort of dialysis sessions there. Anyway, and ideally, if you can get them to limit their sodium intake, that'll help out with the blood pressure, and then stop smoking, get more exercise, all of which is very helpful. In terms of patients with diabetes, they need to be on an ACE or an ARB, mainly because this is going to help prevent that progression. And it makes sense if you look at the mechanism here. At the glomerulus, remember there's the afferent and the efferent arterioles, and remember that ANG2, angiotensin 2, is going to cause constriction of the efferent arteriole, and that causes increased pressure to drive filtration, right? Because again, you're kind of closing out the outlet there to increase pressure to cause filtration to happen. And again, these patients are chronically doing that at a very high level, and again, that causes stress on the glomerulus. So by giving these patients an ACE or an ARB, that's going to release or decrease that angiotensin 2 concentration. It's going to relax that efferent arteriole and allow for less pressure there. Now, if someone has long-standing chronic kidney disease and you give them full dose ACE inhibitor, you're going to cause an acute drop in the renal function. It's not what you want to do. So again, with these patients, you got to start low and go slow, because if you go full blast, it's going to drop their kidney function pretty drastically, and you can end them up in the hospital, right? So start low, go slow with that sort of thing there. And then make sure to watch their potassium, because very frequently these patients tend to not be able to clear potassium as well, because the kidneys can't clear it as well. And you can see hyperkalemia, which we know ACEs and ARBs can raise potassium levels as a function of their effect on things like aldosterone and inhibiting aldosterone release, right? The other big thing too is if they're on metformin, you need to stop this once their GFR gets down below 30 mLs per minute. So this will be contraindicated if they have pretty severe, more late-stage kidney disease. But before that, they may be able to use metformin safely, and that can again be useful from the diabetic standpoint. Which again, if you fix the diabetes, that helps to release some of the stress there on the glomerulus and save some of that kidney function. So these are kind of two things you want to do up until a point. Now, if I have a patient who came in and their potassium, a normal potassium 3.5 to 5, and they came in and their potassium 6, I'm going to stop their ACE inhibitor. I'm going to stop their ARB because that's too high, and that can increase their risk for things like, arrhythmias and whatnot. So you got to be really cautious with that. Make sure you're watching and evaluating that based off the basic metabolic panel. With hypertension, we certainly want to get their blood pressure down below 140/90. If they are having pretty significant proteinuria, then 130/80 is going to be a better option for them. If they have diabetes, ACEs and ARBs are going to be first line. So kind of two birds with one stone in that case there. And you will find very frequently that a thiazide is not going to be sufficient. So you may need to utilize, maybe multiple diuretics in some cases, but more often than not, they're going to have other disease states that sort of dictate what blood pressure meds they need to be on. So if they have a history of MI or CHF, they're probably going to be on a beta blocker and an ACE inhibitor and maybe a loop diuretic, and so they're going to be on other stuff anyway. And so that as long as the pressure is being dealt with, then you're fine from that standpoint. So then getting into some further management in terms of like getting into new drugs that we haven't talked about so far. Let's talk about the anemias of chronic kidney disease and how we can help to manage that. Our goals for these patients are to help out with their oxygen carrying capacity, help out some of that fatigue that we're talking about, and decrease those signs and symptoms of anemia there. And ideally, we'd like to not need transfusions because that can become challenging because one, you may have some patients who refuse transfusions due to things like, religious beliefs. So like Jehovah's Witnesses will not take external blood, right? So that could be a patient who will refuse all transfusions. And then you're stuck with the patient as a hemoglobin of 7. And you're like, well, we got to do something about this, but you don't have a lot of options at that point there. So if you can try to head that off, that's good. You can have allergic reactions to blood, so from coming from other people. So if you don't need to use that, it's going to be a good thing. And so what we're going to do for these patients is utilize erythropoietic stimulating agents, or ESAs, and then iron supplementation. So we'll kind of get into the details of that. And really, you're just using the hemoglobin for your monitoring. You'll also do your iron levels and whatnot to make sure those look good as well, to make sure adequately supplemented. So typically what we're going to shoot for in terms of hemoglobin is to not shoot for a normal quote-unquote level, because what's a normal level for an adult patient, maybe between 14 to 16 grams per deciliter. We're actually not going to go above like 10 or 11 for these patients. So it's not a quote-unquote normal, but it's good for them. It's generally going to be sufficient for their cases. The problem with getting their hemoglobin up to normal, quote unquote, is that they tend to, the blood gets kind of more viscous when they're using these ESAs for these patients here. And as things get more viscous, the flow is going to be reduced, and that can lead to sort of like a sludging of the blood, which leads to impaired flow through places like the lungs or places like the heart or the brain, which are pretty important organs that have blood flow kind of being maintained. So you'll use these agents to try to get, usually when they start to get below 9 or 10, then you're going to initiate the ESAs to try to get them up to about 10 or 11, and that's where you want to keep them for the most part. You try to keep patients with hemodialysis a little bit higher, mainly because, they're going to get a lot more lab draws or getting that hemodialysis where you're getting the blood actually taken out of them and then filtered and put back in, so you're going to lose some red blood cells there. So that's why we do that. And so that's a black box warning about the high hemoglobin levels. You can kill someone with this. They can stroke out if their blood gets too thick, basically, due to this increase of erythropoiesis that's happening here. Keep in mind as well that you can give them all the ESAs you want. And again, these drugs are expensive because they're protein based. We're replacing the erythropoietin they're not making. You can give it to them all day long, as much as you want. If they don't have good iron stores, it's not going to do you any good, because you have to have iron to make hemoglobin. So that is something that you will frequently find, especially like on an outpatient basis, is that they're giving them something like apoetin, but they are not supplementing the iron, or the iron they're using is not going to be sufficient. We'll talk about why that is in a little bit. And you're just kind of throwing your money away at that point. Okay. So you have two options here. We have erythropoietin alpha, which is Epogen or Procrit, and then we have darbepoetin Aranesp. Again, as I mentioned, that black box warning, increased risk for death, stroke, VTE, all of that has to do with driving up your hemoglobin too high. If anyone's familiar with like blood doping, this is kind of a similar thing that happens here. Like I'm sure, I know there's a few cases of like cyclists who have either doped their own blood, or they're using erythropoietin stimulating agents or something like that. And then when you're cycling, you're being very physically active, you're going to get a little bit dehydrated, and that causes even worse viscosity of the blood, and then they stroke out and die, right? So there's certainly been some cases of that. You don't want to do that to your patients, obviously. There could be some risk for cancers here, but it's relatively low. It has not been sufficient enough to need to take the drug off the market or anything. So, but that's something at least to be aware of. And then how often you give it may be based off of their hemoglobin levels. Depends on the drugs, like erythropoietin or epoetin. You're going to be given like 3 times a week generally, whereas darbepoetin has a longer half-life, so you can give that like every 4 weeks or so. So that can be some benefits. In terms of adverse effects, you definitely want to watch the blood pressure, because that will tend to increase here as you're getting more red blood cells being formed. And then they can also cause issues with their vascular access. You can find they just can like kind of clot over. So whether they have like a fistula that's in place for dialysis, or they have like some kind of central port or something like that, that can clot over and can cause loss of that, which is not great because then you have to replace it. So, as I mentioned, with iron status, you're going to find that most of these patients, if not all, are going to require some kind of iron supplementation. You also want to make sure that their B12 and folate levels are going to be kept in check as well, just because if you don't have those, you're going to get anemia anyway. You need this for normal red blood cell production. The challenge, though, is that iron absorption is going to be pretty insufficient for a lot of these CKD patients. Only about 10% gets absorbed here. And I don't know if anyone's ever taken iron supplementations, but it's pretty rough on the stomach, which is also going to be kind of a complication here. There are quite a few options and preparations that are available. Probably the most common ones you're going to run into include things like ferrous sulfate, ferrous gluconate, and ferrous fumarate. There are others that are out there. One thing I will caution you with when you're looking looking at labels for iron products, or if you're recommending iron products to your patients, to make sure they are reading the labels appropriately. They're when you look at things like this, they may have like the milligram amount of iron salt that's here. So like, for instance, if a ferrous sulfate tablet is 325 milligrams of ferrous sulfate, that's not all just elemental iron. And usually they'll list the elemental iron out separately. So they'll say, okay, well, this is ferrous sulfate, 325 milligrams, 65 milligrams of elemental iron. That's the thing you want to focus on. That's the thing you want to make sure you're dosing on. And again, that will be different depending on the salt, just because they have different molecule sizes, and that can affect the milligram amount. So make sure when they're looking at the labeling, they're looking at the elemental iron content. And sometimes the labeling is hard to read, even for healthcare professionals. I was helping out my wife, who's also a pharmacist, because we have a family member who's pregnant. We're trying to find a good prenatal vitamin for them that had enough iron. And again, it was difficult even for us to read the label to figure out, okay, wait, are they talking about the elemental iron content? Is this the iron salt formulation? So they don't make it easy. So just be careful when you're recommending to base it off the elemental iron content. That's what the dosing you'll find is going to be based off of. So there's also some IV preparations. We'll have things like iron dextran, sodium ferric gluconate, iron sucrose, and then furomoxetol. That's going to be our main IV options that are there. From a GI standpoint, these are pretty rough on the stomach. A lot of cramping, a lot of constipation with this, and is going to be a reason why a lot of people don't stick with it. So compliance is going to be hit or miss with this one. It can also cause a blackened discoloration of the stool, which is important to warn about, mainly because, black stool, you think GI bleeds. And so if you can warn them about that, just say, hey, this is normal, they won't freak out, hopefully. So for patients who cannot absorb enough orally, or, there's all kinds of food-drug interactions and drug-drug interactions we talked about, everything binds to iron, it seems like. But if they can't get enough good oral absorption of this, then we need to utilize intermittent IV administration. And so sometimes they'll get this when they come into the dialysis center, so they can kind of kill two birds with one stone. But the big things you have to watch out for with the IV iron preparations are things like allergic reactions that can happen here. And they can also get this like hypotension, dizziness. This can come about from rapid infusions. You want to make sure they kind of slow that down so they can infuse over an hour to 2 hours. That can help out to mitigate some of those reactions. And again, that's another couple of hours of patients being held up for. So again, you want to think about things like their lifestyle and how much time they're having to devote to this stuff. You can also see some arthritis and arthralgias associated with this as well. So how you select it, basically use oral if possible, because there's fewer systemic side effects. Generally you're going to be cheaper for the most part. Just use have them try different ones and try to figure out kind of what works best for them based off of side effects and costs and things like that. And then, as I mentioned, typically patients on renal replacement therapy on dialysis are going to require IV preparations. They just can't get enough absorbed orally. And then you'll monitor the iron status, every 3 months or so while they're on ESA therapy. Usually when you're kind of trying to adjust initially, you may do it a little bit more frequently, so like every month or so. And then you can kind of back it out once they've sort of stabilized on their dose there. And again, if you're on dialysis, you're going to be monitoring pretty closely anyway. They're coming in multiple times a week, so it's not too hard to get those labs done when you need to, basically. So I think I'm going to cut off there. I don't have enough time necessary to jump through all of this without going over. Does anyone have any questions for me about any material we covered today. I think you guys saw my announcement about the exam, and as I kind of put the most salient points there. Any questions from the exam you guys had? Any points you weren't sure about, perhaps? You guys are a little more quiet today. Maybe I'm missing some people, though. I know some people are probably behind from going to talk to the accreditors. Well, if there's nothing else, you're certainly free to leave. I'll stay on for a minute or two, just see if anyone has any questions. But I hope you all have a great weekend. I will see you next time. I'm going to try to get those prescriptions done. A little delayed this week. It's kind of hectic, but that's no excuse to you, I'm sure. But yeah, so I'll fix that main page there. It's just more clear. We have another quiz, and that'll be on the 9th. Oh my goodness, 3 exams next week. Hey, at least it's not one of mine. That's usually a good thing, right? Any week's a good week if you're not taking one of my exams, I think. This is a general sentiment I've heard from people. My Nova students they had a nephro exam today, and then they have one of my exams on Monday, so they're really suffering. They're gonna have a bad weekend, I think. Any other questions? Or any questions? Here you go. Someone popped in here. I was like, can you supplement hypothyroidism by just taking, having the patient take more iodine? Potentially, right? So you have to look at like why the patient is not producing their thyroid gland or thyroid hormone in the first place. If it's due to low levels of iodine, then absolutely that could certainly help out, right? And so, generally speaking, though, in developed countries, that's not as much of a problem. So you may want to inquire about their diet to see if they're getting, sufficiently varied diet. The malnutrition aspect of it is generally not seen in the U.S. as much, although it's not impossible, right? You could have people who are, very, food insecure who may have iodine deficiencies, in which case, yeah, supplementation would fix that. But most patients with hypothyroidism have some other reason for not being able to form as much, either due to and again, it could be a primary issue with the thyroid glands just not doing it. It could be a pituitary issue. It could be a hypothalamic issue. So it really just depends on the situation there. But yeah, so in some cases, yes. A lot of cases, no, unfortunately. How does the exam give back work? Yeah, so that's a good question. So I think there's one partial, one full. Here's how exam give backs work. If I decide that I'm going to give a give back, I can decide to do it for certain answers, or I can do it for all of them. Okay. So the way that I determine that is basically if I look at an exam question and I see that it's like super scattershot. And again, we also look at a lot of the stats. I don't want you to think we just do this like kind of willy-nilly, but if you're interested, this is kind of the process. If I look at an exam question and I see that it's like, and again, one of the tools we use, and this is kind of in the weeds, but it's called a biserial number. And it basically tells me the people who perform really well on the exam on average, were they all picking the right answer? Or were they picking a different answer? And if I get a really high biserial, that means that the people who did well on the exam really knew their stuff and they knew that this was the right answer. And so that they picked that. So that's generally a good thing. You want to see a good biserial. And that way it also indicates people who did poor on the exam did not pick that answer. So that's usually a sign of a good functioning test question. If I see a low biserial and like the answer choices are all spread out throughout the question, so like 10% did A and then 20% did B and it's just spread out, I just do a full give back. I just assume that I did not teach that concept well, or something was funky about the question, wasn't clear, something like that. I just say, okay, I'm going to do a full give back. If it's pretty clear that I either, so that's a full. If I do a partial, it's generally because there were maybe 2 right answers. Maybe I picked a bad distractor and that wasn't really appropriate, or if there was like a missed key or something like that, in which case I'll just give credit back for that one particular answer. And so whoever picked the original right answer still gets credit for that. And then whoever picked that other wrong answer I do the partial for gets credit for that as well. No one who got it right at first gets extra points for that, okay? But if you had picked that one answer before that was originally wrong, now it's correct and you get 2 points for that. So that's generally how they work. If you have questions, I don't mind talking about the process, because I like to be transparent about that stuff, just so people feel like they're getting a fair shake. Someone asked for chronic kidney disease. You mentioned that they have a high potassium. Will they automatically have low sodium? Is there a teeter-totter effect? That depends. I generally find that sodium is not as huge of an issue for those patients. They can tend to regulate it fairly okay. Obviously, a lot of times they will be in a more kind of like hyperaldosterone sort of state. Because of things like chronic hypertension and things like that. So that would obviously lose potassium. But because they have the kidney injury or the kidney disease, they can't clear it as well. So they just tend to hold on to potassium. The sodium tends to not be a big issue. But yeah, hyperkalemia is a big concern. And I mean, that has killed several, many patients with chronic kidney disease. So not really teeter-totter so much. It's just they hold on to extra potassium for the most part. Any other questions? Thank you for providing those. I like to be able to talk about those things, make sure everyone has good, clear knowledge of the stuff. Because nephrology is hard, You said, with patients who have a pre-renal acute failure, why do they have a high specific gravity while patients with intrinsic acute failure have low specific? That's a good question. I don't know if that's outside of my purview necessarily. So if you think about it, what is specific gravity, right? It's basically how concentrated or dilute the urine is, right? So if you have a very low specific gravity, it means that the urine is very dilute. If you have a high specific gravity, it means it's very concentrated, right? So what you will find, I do some home brewing of wine and things like that. So I use specific gravity to check how much alcohol was made and stuff like that. So that's my main utilization of specific gravity. But one of the things you're going to find is that if you have a pre-renal problem, right, you don't have enough blood flow getting to the kidneys, right? Your kidneys are going to be in a state where they say, hey, there's not enough flow here. We need to save everything we can, right? So it's going to try to concentrate everything as much as humanly possible. And then the urine that you get out of that's going to be pretty concentrated. So you'll see a high specific gravity with that pre-renal issue, right? So that could be due to vomiting, bleeding, whatever you're doing that's not providing enough blood flow to the kidneys. They detect that and they say, we got to concentrate everything because we need to hold on to this fluid. Okay, they hold on to this water as best they can. So things like ADH is going to be a higher secretion, so that means more aquaporin channels. You're absorbing more of that water. Aldosterone is going to be released more. So all that stuff's trying to concentrate and hold on to as much water as you can, right? There's a limit to that. So you still get some urine, but you try to hold on to as much as you can. With an intrinsic kidney failure, this has more to do with the kidney's ability to concentrate that, right? And remember, where do you concentrate the urine at? Well, it's mainly going to be in the, some of it's going to be in the loop of Henle, and then a lot of it's going to be in the distal convoluted tubule and the collecting ducts. That's where you see a lot of concentration of the urine there. And so what you see with that is if you have injury that is impairing your ability to concentrate the urine, then you're just going to spill everything out, and it's going to ends up becoming very dilute, right? And so you can see cases where they're spilling out a lot of electrolytes and whatnot, but yeah, you end up ultimately seeing kind of a dilute urine, which is why you get that lower specific gravity. So hopefully that makes a sense. I know it wasn't something we covered here, but maybe you had it in a different class. If that's wrong, you can correct me. I'll do a lot of urinalysis work in my line of profession, but we can speak to it. All right, well, I don't see any other questions here. If you have anything, feel free to post them up. I can get to it next week, and otherwise, you guys have a great weekend. Stay safe out there, and hopefully you have a good... So David's asking, does that also dilute the serum? No, it has more to do with the kidneys themselves, because the blood presumably is still the same coming through content-wise. It's just a matter of, can you reabsorb all that water in the distal tubule and then the collecting duct? If you can't reabsorb the water, then it's going to come out dilute, and you're going to see that low specific gravity, basically. Yeah, but good luck on your exams next week. Hopefully that help. I mean, you may see some serum effects that can happen, but typically you wouldn't see a dilution because you're not holding on to extra fluid necessarily. If that makes sense. Yep. No problem. Well, thank you all for joining me. Appreciate you, and I will see you next week.